And good evening, everybody. So we have been talking about more of medical subjects and scientific knowledge. But today we are planning to go through some emotions. Um, and even though when you look at palliative care, we know that it is from the start of diagnosis, not only till the end of the patient, but also it should continue through the bereavement period. But often this is neglected because of many reasons. The main one being the lack of resources and many other problems. So today we will focus on grief and bereavement. And as you already know, Smriti, who is my colleague at Parliament, will be uh, handling the session. So Smriti has been working in palliative care for the last 20 years in various capacities and in various institutions. Um, she's the head of strategic partnership and community engagement in Parliament India. And she is the India Advocacy Focal Point for International Association for Hospice and Palliative Care, and she is also a board member of International Care Policy Consortium. Basically, she's a psychologist, um, but has been in palliative care for uh, long years. So, with this introduction, I would like to invite Smriti, and it's over to you.
Thank you. And thank you, Shri Priya. Always find that I have to struggle to be equal to the task. Great to see all of you again. And as I did in my last session, I am going to request cameras be on for a few minutes in the beginning. We can turn them off once the slides begin, because I rely heavily on human connectivity. And this is not a medical class like Dr. Sunil just indicated. We're going to talk today about grief and bereavement. And for that, we are going to scan the room from time to time. We're going to look at each other. We're going to make sure that everybody's in a decent space mentally and emotionally. I will qualify at the beginning itself that this may be a triggering subject for some people. In the last few years, especially having lived through the pandemic, I'm sure there's not a single person amongst us who hasn't been affected or touched by grief, whether our own or people we care about. So you might find that there are certain aspects of what we're going to talk about that might hit an emotional chord. If that is the case, I am going to encourage you to please send me a private message in the chat. I would appreciate it, and we will pivot as needed. And if this is bringing up any difficult emotion for you, I'm going to save some time towards the end of this session so that we can unpack some of those things. Okay, Dr. Sunil introduced me as primarily a psychologist. I did train as a psychologist many decades ago. I don't think I've actively practiced psychology in the traditional sense in a while, but being in palliative care requires you to call on those skills. So hopefully I'm not entirely, rusty. Okay, so to start off with, I think the easier question here is, anyone here who has not experienced grief, put your hand up. Okay, all right. So at least we're all human, and this is something that I think being human is part and parcel of, experiencing loss, experiencing love, and experiencing grief are part and parcel of being human, no matter where we are. And if you have loved anything, you have also experienced grief, because with loving something and losing it, that's an invitation for grief to enter your life. I will also qualify that I will be using a lot of personal examples today. I have checked with Dr. Raj to make sure that it's not an unprofessional thing for me to do. And I believe that actually, especially a topic like this requires humanizing it. And we will be talking about frameworks which will help us understand grief as practitioners who are here to support our patients and their families. But I will also, from time to time, allude to personal example, primarily to illustrate a particular point as we go along. So I see that people are still sort of signing in, Dr. Sunil. So we'll get off to a start because I know that we don't have a lot of time. This is a vast topic, and I am infamous for going over time, which I don't want to.
Yeah, please continue.
All right. So I'm going to start sharing my slides. Is it visible to everybody? Yeah, okay, fine.
Yes, sir.
So although the topic is grief and bereavement and psychological therapies, I am mindful of the fact that I'm not going to go too deeply into psychological therapies because just like doctors need training, so do psychologists. And there's a lot of pop psychology floating around out there. So we're going to try and avoid that. I will just give you basic introduction to some of the psychological interventions that can be utilized. And working as an interdisciplinary team, I would strongly encourage getting people on your team who have specific skill sets and training in providing these kind of psychological therapies. Having said that, by virtue of being a palliative care provider, many of us have these inherent skills, and you've been through classes on communication, you've been through classes on shared decision making and things like that. So that in and of itself, I think, infuses empathy, and that's half the battle won when you are working with somebody who is grieving. Okay, let me just start off by saying that, grief and rituals of mourning are healthy adaptations to loss. And grief is not something to shy away from. It is not pathological. It is normal. It is natural. It is a natural response to a loss. And mourning is the expression of that grief. And very often, the ways in which people express grief, the way in which society condones the expression of grief has to do with the culture, the social context, and also the family dynamics and the kind of family that you belong to. Okay, so grief is a response to loss. And so tell me now, you've been through so many sessions on palliative care. The death of a person is not the only loss. What are some of the other losses that people experience from the time of diagnosis? Because palliative care ideally should be brought in from the time of diagnosis. So what are some of the losses that people experience from the time of diagnosis? Feel free to use the chat box. Feel free to unmute yourselves. What are some of the losses?
At the time of diagnosis, most of the patients feel that something, their future has been blocked. That is something like loss of the future plans, the roadblock to the future plans, what they have done, what they are about to do. It could be related to the personal stuff or with the people surrounding around them, or something which they are going to do for their beloved.
Absolutely.
You are not audible, Ravi.
So Ravi, from what I've heard, you've said that it's a loss of future, it's the loss of opportunity, of plans, and the loss of basically things that you had planned for in the future, and that is lost once the diagnosis comes in. Yes, you're absolutely right about that. I see that people have said, okay.
Yeah, there are a lot in chat.
Yes. So independence, loss of employment, hobbies, control, dignity, autonomy, loss of physical closeness, financial loss of optimism, loss of peaceful sleep. Oh, yes. So you've got it all covered, I think. And there is a loss of identity as well, because the minute somebody is diagnosed with a I'm just going to request that people mute themselves, please. I'm getting some sort of feedback. Okay. Yeah, the minute a diagnosis comes in, suddenly the person becomes a patient. And it's not just to the medical fraternity, it is also to the family, right? And from being the mother and being the caregiver, the nurturer, the provider, whatever, suddenly this person is a patient and needs to be taken care of. And in our love, we sometimes strip them of their identity even more. Somebody who can help themselves to a glass of water, we don't let them do it anymore. We do it for them. Nay, I'll do it. I'll do it. So whatever they had as an identity is also lost. Now, if I were to ask you in this room today, who are you? Who are you? How are you going to answer that question? How would you introduce yourself? How do you identify yourself? Use the chat box. What's the first thing that you would say about yourself?
About my name, my profession,
Name and profession.
regarding the work, name and profession are the two first things which I introduce myself to anyone.
Okay. All right. And so it's stuff that who you are and what you do. And now you have a disease diagnosis and you can no longer do that. Now, who are you? Okay, so this is a rhetorical question, but the loss of identity is a big one. And sometimes the way the system works is you're reduced to a case file, a case number, a bed number, a room number, cancer patient, CA pancreas, whatever it might be. Okay, and the customary role that you have in the family, you might be the fun-loving brother. You might be the indulgent grandparent. Those are roles that you have apart from your professional life. And those roles are also diminished after the disease diagnosis happens. Physical function, depending on the kind of disease prognosis it is, it might be a traumatic spinal injury, it might be anything. It could be a debilitating illness, it could be anything of that sort. Physical function is lost, and that is a big loss. Okay, relationships are lost. And why are relationships lost when there is a disease diagnosis? What kind of relationships are lost? Why is relationships something that we're counting amongst losses?
The physical balance, the emotional connectedness, the mother to care a son or the husband or the wife, the roles which they play, they set back. They step down because of their illness.
The roles change. But there are some relationships that are lost, like Jagriti is saying in the chat box, social relationships. You can't go out and meet your friends. You can't go out and maybe, your social interactions are diminished. If it is a disfiguring illness or if it is a stigmatized illness, sometimes you are cut off from society as well. If it's a disfiguring illness, like maybe, head and neck cancer, the person itself might withdraw from relationships, right? From social interactions. And you realize that, okay, maybe people who are your friends are not really your friends, or friends are trying to get in touch with you, but you're too sick to meet them. And over a period of time, they also stop visiting. So relationships are lost. There is a huge material and economic loss because we all know that healthcare is not cheap. 55 million Indians are pushed below the poverty line annually because of healthcare expenses. People, they mortgage their homes, they sell their assets, they reallocate their funds. So the material and economic losses are tremendous. Time. We lose time, not just in terms of life expectancy, but time in terms of how many hours in the day you have. How many hours go towards going to the hospital, setting up appointments, going for scans, waiting in line to get an MRI, waiting for your test results. All that time, there is time shrinkage, both for the patient as well as for the family. We lose time that we would have otherwise used somewhere else, maybe in our hobbies, maybe in our work, maybe in nurturing the children in our family. So time is lost. Opportunities, like Ravi said, your future, so many opportunities. Maybe you were up for a job promotion, that's gone. Maybe your child was ready to go off to college, and now that money has to be reallocated towards treatment. So that opportunity for that particular kind of education is gone. Opportunity to travel, opportunity to relocate to another city and take up another job. All those opportunities are gone. Again, it's for the patient as well as for the family members. Plans. How many of you remember your plans in 2020 February? February 2020, I'm sure all of you had great plans. And then came COVID. What happened to those plans? And this is just, that's a pandemic. Of course, everything changed because of lockdown and stuff. But plans for you as an individual, when you suddenly have a life-limiting or life-threatening diagnosis, Your plans completely change. And the plans that you maybe nurtured since you were a young person, those plans are gone. Autonomy. Somebody mentioned that in the chat box. Autonomy. What is autonomy? Autonomy is my right to decide what I want for myself, my right to self-determination, my right to be an individual in my capacity and exercise my capacity to do things, to decide for myself. Now, what happens when you become a patient? All the decisions are made for you, from the doctor to the nurse to your spouse to the uncle's neighbor who has tried some doctor somewhere else. He also has a say in what's going on with you. Your autonomy is taken away from you and decisions are made for you. And this is, I mean, there are some of us who still retain that autonomy, but for a vast majority of people, autonomy is sacrificed. Okay. And autonomy is something that can be practiced even if somebody is completely bedbound, because autonomy is here. My ability to make a decision for myself is here. But people have to enable that around you. And if people take that away from you, then you lose it. And like I said earlier, very well-meaning, loving relatives will take your autonomy away from you because they think now that they know what's best for you. Control. Someone has mentioned that also in the chat box. I have suddenly lost control over my life. I have no idea what the next day is going to look like. I don't know what 1 year is going to look like. And the loss of control, especially for people, I've seen this happen so many times where it's an older person who has a disease diagnosis and somebody who's been in charge of the family, somebody who's been the leader of the family, and now they suddenly have no control anymore. And then a lot of the times I hear younger to middle-aged children saying, God, this person has become so stubborn. That stubbornness is a manifestation of trying to exert some sort of control in a life where otherwise control has been taken away. And let's not forget dignity. The way the healthcare system sometimes works is that it strips us of our dignity. And you were all there for Harvey Chorchinov's class on dignity, right? What is dignity? Dignity means different things to different people. And dignity is taken away. When your autonomy is stripped away, your dignity is also taken away. When your independence is taken away, your dignity, for some people, their dignity is tied in with their independence. For some people, their dignity is tied in with their work, their profession, the amount of respect they get from society because of the work that they do. And when that role is taken away, their sense of dignity is also taken away. But at a very, very basic fundamental level, you're lying in a hospital bed and suddenly there's grand rounds and the doctor comes in with 15 medical students and then they strip your sheet open, they change your catheter in front of complete strangers. All of that is an assault on dignity. And not calling somebody by their name is also is a process by which we take away somebody's dignity. We take away their identity. Okay, so these are a functioning member. Now, in a family, it's a huge loss to lose a functioning member. They might still be alive, but they're not able to do the things they used to do. And if you think about your own families, you know that there are people who take on particular functions and roles. Some people are the conflict resolvers. Some people are the practical fixers. Some people are the people who manage the finances. There are people who are basically there to make everybody laugh. And those are functions that we perform in our own families. And sometimes that function is lost, that role is lost. And all of these different kinds of losses warrant grief, not just the death of a person. So this is just to set in context what we're talking about when we're talking about grief. And grief is a complete human experience. Okay, grief has, of course, it's the emotional aspect of all those different emotions, but physically, we feel grief in a physical way. Now I'm going to ask you, where do you feel grief? When you feel sad, where in your body do you feel it? Is there a place in your body that you feel it? Where does it show up? Where does it show up? In your heart, in your eyes. Where else? Head, as a headache. In the mind. Okay, physical. Let's keep it physical. Where in your body? Where in your body do you feel it? Fatigue, so loss of energy. Action. In your mood. Okay, that's again emotion. Come back to the physical. Let's make these distinctions. Physical. Breathless. Yeah, people get choked. They choke up. Heaviness in the chest. tightness in the chest. Yeah. So there is a very, very strong mind-body connection. And grief is a very powerful experience that can and will manifest in your body, in sleeplessness. In, when some people, it affects their appetite. When I'm sad, I eat a lot. And that's also a physical manifestation. I'm just hungry for comfort food. How many of you raid the kitchen when you're feeling sad? Okay, so it is a physical experience. Grief affects you cognitively. Now, cognitively is different. Cognition is your ability to make decisions, your formal operational thought, decision-making, problem-solving, paying attention, concentrating. All of these things are affected when you're deep in grief. Have you tried to, how many of you experience decision paralysis when you're feeling grief? So hard to make a decision, so difficult to make a decision when you're feeling sad. Yeah. So hard to concentrate. So yeah, feeling blank. So I did say that I'm going to be sharing like a little bit personally. And the thing is, I lost my mother about 2.5 months ago. And my decision-making capacity actually got better because it became sharper for me. So it's not always that it goes away. Sometimes it becomes sharper for me because that's where my grief manifested. I wanted to solve the problems. I wanted to solve, I needed to. But then when I actually sat down to do accounts, my attention would wander. I couldn't concentrate. I had to come back to work, and when I had to read the document, I found that I was reading the document 5 times because every time I read that document, I missed out a paragraph or I'd forgotten what the previous paragraph said. And it took a lot of attention. I mean, what would have taken me maybe 3 hours to do took me 6 hours to do. Actually, it took me a week to do. I'm lying. It took me a whole week to complete a cognitive task, and that's another manifestation of grief because it does show up in the way we're able to think and process. Grief is a spiritual experience, and by spiritual, I don't mean just religious. It includes religious faith, but what it also means is meaning, purpose, hope, connection. You feel disconnected. Some people feel completely disconnected from others. Some people, are looking for meaning. Why did this happen? Why is this happening? This person is a good person. Why is it happening to them? What did they do to deserve it? What does this even mean in the larger scheme of things? And your belief that I did everything right. Why is this happening to me? Okay. It is an emotional experience, of course, and emotion is sadness the only emotion in grief? Is sadness the only emotion that you feel in grief? Parul, yeah, you start seeing the world as a third person. Yeah, you have a sense of disconnectedness or a disassociation. Yeah. Okay, so no, sadness is not the only emotion. Anger is a big one. What else? What else emerges in grief? There's a tendency to think that grief is all sadness. It is not. There are some very, very complex emotions that come up when somebody is grieving. Okay. We will talk about that a little bit more as we go along. Restlessness, yes. Social, grief is a social experience because we're all connected, whether we are recluses, introverts, extroverts, high-functioning introverts, we are part of a larger social fabric, and grief has an impact. It is affected by our social connection and it affects our social connections. The way we handle grief has a lot to do with how much social support we have. Also, the way we are internally built as people then has an impact on how we connect with other people socially. So grief is a full human experience. It's not just an emotional experience. Okay. And what are some of the factors that influence grief? Attachment styles. And I'm just going to ask you to refer to Mary Ainsworth's study. Attachment styles is how I attach to somebody. And these attachment styles, those of you who are familiar with psychology and with attachment theory, with Bowlby's attachment theory, it's there in the module notes. We form these attachment styles very early in life as very, very young children. And it entirely depends on our primary caregiver. Some of us are insecurely attached. We cling, we cry when that person is not around. We have separation anxiety. Some of us are healthily attached in the sense that we have secure parents, we have secure primary caregivers. So we know that if they're leaving the room, they will come back. So you can see when a child is securely attached or insecurely attached, or there's avoidant attachment styles and so on. But the way we attach and we form these attachments pretty much gets enhanced as we go along, unless they're really unhealthy patterns, and if we have the good sense to get ourselves some therapy. But these attachment styles become stronger and stronger as we go along. And if we are unhealthily attached to somebody, the grieving process is affected by the way we have formed an attachment. If I'm attached to my mother in a way that I cannot function without her, my grieving process is going to be very, very different from somebody who has learned how to be independent and who has a healthy relationship. Family structure. What kind of a family structure do you have? Are there lots of people in your family? Who talk, and how is the family structured in the sense that is there a parental unit, a sibling unit? Are there people who talk to each other more? What are the boundaries? Is there someone in the family that you don't reach out to for comfort? Who do you reach out for nurture? Is the family flexible in a time of crisis, or are they rigid in a time of crisis that no, if this is a problem and this is how we're going to solve it, and only I am the decision maker, versus, hey, let's get together and figure this thing out. Okay, so the way the family is structured will also affect the grieving process. Communication patterns within the family, like I just said, a family structure and communication are very closely intertwined. And the structure of the family is, okay, who's there in terms of the generations and in terms of aunts, uncles, extended family, and so on and so forth. But communication patterns are very unique to families. I might be close to my mother's sister, who I go to as a confidant, or I might be close to my mother, who is the patient, and now suddenly I can't talk to her about my worries and my concerns because it would worry her some more. So communication patterns within the family will also determine how the grieving process is experienced. Okay. And finally, social support. How much social support do you have outside of the family? There are cohesive families who also engage with a larger community, who have maybe church groups, who might have clubs that they're part of, or, circles of friends that they rely on. And those people tend to have better coping strategies than families who are isolated and are closed off and who don't share. There are families who will not ever share their difficulties with others. It's not allowed. And that also is reflective of the kind of communication pattern there is within the family. And those people, individuals within families like that, find it very, very difficult in times of grieving. So attachment style is a very individual thing. There's family structure and there's social support. So if you look at it, it's at all levels, going from the individual to the macro level. Yeah. Now, the most famous theory of grief is Elizabeth Kubler-Ross's 5 stages of grief. Okay. Everybody who has experienced palliative care or has, it's so much a part of pop psychology, popular psychology now, like the 5 stages. But there are a lot of misconceptions. Elizabeth Kubler-Ross was a pioneer in the way that she was able to streamline and talk about the experience of death and dying and the attending emotions. But there is a misunderstanding sometimes where people think that you have to go through all 5 stages. And the 5 stages are denial, anger, bargaining, acceptance, I missed one, depression. But that's not true. You don't necessarily have to go through all 5. Sometimes you will go back and forth. Sometimes you will reach acceptance and go right back to being angry. I have accepted my mother's death, but I'm still angry at a lot of things. Am I regressing? No, I'm just being human. I don't have to go through the denial phase. Maybe right from the start as a caregiver, I knew exactly what was coming. So I was not in denial of a terminal illness. But did it stop me from bargaining? No. Please let her live past the new year. That was a big thing for us because in early December, we did a prognostication and her prognostication was not good. So in December, I called the whole family. My brother lives in Dubai. I called him, his family. I called my cousins. My mother was the matriarch of our family. And I said, come, I don't think she's going to make it past New Year's. So everybody came, they spent time with her. She pulled through another month. But there was an internal dialogue in bargaining saying, please, let her live through this so that she can get to see all these people one more time. So this is also part of the grieving process. And so you may miss a stage, you may revisit a stage, you don't have to go in sequence, you can go backwards. So these are just some of the primary emotions and states of being that people experience when they're going through the experience of grief. There are some more contemporary frameworks of understanding grief, and I'm just going to go through a couple of them. the tasks framework, which is by William Worden. And for those of you who are familiar with developmental psychology traces the psychological evolution and growth as you go from birth to death through the many cycles. So through adolescence, through adulthood, marriage, having procreation, whatever, like all the different stages that people go through in life. And the tasks framework emerges from that. And just like a child is required to accomplish certain tasks in order to move on to the next task, similarly, Worden says that when you experience loss, you have to go through specific tasks, master the task, and then that allows you to master higher order tasks. So for a child, before they can run, they have to be able to roll over, they have to be able to crawl, they have to be able to walk. And only when they do that can they actually start running, right? And similarly, mental and neural development also happens that way. I cannot become an abstract thinker when I'm 2 years old. I have to go through all of these developmental, neurobiological developments in order to get there. So that's the kind of framework that Worden uses. And it is influenced, these tasks are influenced by what are known as mediators of mourning. I will tell you what that is in just a minute. Now, what are the tasks according to Worden? And this is a 1982 theory, and it still holds good. The first task a person who has experienced a loss has to master is to accept the reality of the loss. Okay, so here I'm specifically taking into context death. Okay, we're talking about death as a loss. Firstly, you have to accept that the loss has happened, the person has died, and they will not be returning. Sound simple? Sound simple? Do you have examples of how people have not completely accepted this? There are people who will turn the room of the deceased into a shrine. They will not get rid of their clothes. They will leave things as they were. Okay, so you may have mentally accepted that the person has died. Emotionally and spiritually, that loss is not fully accepted. Yeah? Anybody has any thoughts on this? Does this make sense? Okay, all right. So firstly, so it's not as easy as accepting, the person is dead. The person has died, they're not coming back, I have to move on. The second task is you have to process the pain of grief by experiencing and expressing all the associated emotions. It's very painful. And the pain is not necessarily sadness. For some people, it's anger. It has been 2 months since my mother died. My primary emotion, even today, is anger. And it's not because I didn't love my mother, but I have a lot of anger about various things, an entire lifetime of things. And right now I'm seeing a therapist, I will very honestly tell you, because I'm trying to process this anger. I want to get to a point where I can actually feel sad and grieve. I look at my brother. In the last 2 months, I've seen him cry, I've seen him break down. And at the end of it, I'm jealous of him. Because how can he feel that so beautifully and I'm still dealing with anger? I don't even know what I'm angry about. So, but the thing is not to shun it away. The thing is to process it, understand it, get help to process it. And once we master that, and this is not sequential, but at least the process has to be acknowledged and begun. The next thing is to adjust to a world without the deceased. Person is gone. Now what? And what does that adjustment mean? It means different things to different people on a day-to-day basis. I came back to where I live in Tamil Nadu after 5 months. I was in Allahabad for 5 months looking after her. I finally come back to my own home. The last time I was here, I would call my mother twice a day, in the evening and in the afternoon. Even today, I forget that she's not there to call. It's an adjustment I make every day because my hand reaches for the phone and I'm like, oh, okay, she's not there. That's one kind of adjustment. The other kind of adjustment is, what role did that person have in your life? Were they the ones who used to change a bulb, get the car serviced? Who handled all the bank accounts? who did all the decision, household chores, who organized the children before they had to go to school. And those are the adjustments that you have to make in a world without the person who has died. And this is where the grief starts to come, because it's not in the big, gaping loss that everybody acknowledges. It's in these small losses that you have to relive every single day that real adjustment comes. And this particular phase takes a very long time. And finally, the last task is to emotionally and spiritually relocate the deceased and engage with life. What does it mean to emotionally and spiritually relocate the deceased? What does that mean? Anyone want to guess? To emotionally and spiritually relocate the person so you can move on with life. I'm going to just pause for a second. I know this is heavy stuff, so we're just going to pause here. To emotionally and spiritually relocate somebody. When a person...
Yeah. When my grandmother was deceased, of course she was 93, but I have a strong emotional connectedness with her. When she was deceased, everybody around her, including my mom, my sister, they sobbed and in very heavily and this and that. But I was like, I haven't shown my tears in front of them, but I have told them that she will come back again as my kid. She's not deceased, she would have left now, but she will come back to me with me, and she will connect me as a kid to me. So I'm not crying now that she was left. It is a way that she will be coming back to me. I have enjoyed as a grandson, and she has pampered. Now it is my turn that I will pamper her as a kid. So that is the way she has left now. That's the way I think this was something I can reconnect with her, with that grief.
So what you've done there is quite beautiful. It's you have made meaning out of it. Now, spiritually and emotionally relocating somebody also means that when a person dies, does our relationship with them end? No. So my mother has died. Does that mean that she and I are not mother and daughter anymore? She still has a place in my life, right? And how do you relocate somebody? You say, okay, sometimes people do it by, like what you said, like maybe the baby is going to be named after your grandmother, or some people start a scholarship in the name of the person who has died. Some people go and plant a tree. Some people, write letters, or they will have internal conversations with them. So it's there, they're still there in your life, but you have also moved on. There's this really beautiful book. It's right here. It's called Continuing Bonds. And this is a very specific theory from within palliative care. It means that your bond continues with the person even after they're gone. And how do you make meaning out of it? That is to spiritually and emotionally relocate them and move forward from there. Okay, so those are the 4 tasks according to William Worden. And again, to reiterate, these tasks are not necessarily sequential. They may overlap and they may require revisits, but by and large, you are not going to be able to spiritually relocate a person until you have fully accepted that the person is gone. So certain things have to be accomplished before you can move on. There's a woman called Therese Rando, who 2 years after William Worden's theory, she came up with this idea of mediators of mourning. Okay. And she says, in order to really help somebody mourn and work through these different tasks, you have to understand these 6 things. Okay. And what are these 6 things? What was the person's relationship with the deceased? Was it not just in terms of parent, child, spouse? No. What was their relationship? Was it conflicted? Was it nurturing? Was it healthy? Was it unhealthy? Was there abuse? Now, the person who is deceased could have been an abuser, right? So the nature of that grief is very different from somebody who's lost a very nurturing person in their life. The circumstances of the death, okay, was it sudden? Was it expected? Was it painful? Was it away from home? Was it in a way that you didn't anticipate? For me, I was with my mother 5 months non-stop, day in, day out. I stepped away for 1 week. She died the night before I went home. And I watched her die on a video call. To me, part of my anger comes from that. That after having, with all my experience in palliative care, having taught grief and bereavement for the better part of the last decade, I did not know how to come to terms with the fact that at that moment, I was not there. And it was technology that allowed me to see her die. So circumstances of the death will mediate the mourning period, okay? The person's coping style. What was the person's coping style? Are they the kind who will seek support? Are they communicators? Are they the kind who will get help? Are they the kind who will shut themselves off? And the person's coping style is largely also determined by the kind of family that they belong to. And please remember that coping styles will only get enhanced in a time of crisis. If you have a healthy coping style, it will come in handy. If it is a dysfunctional coping style, the dysfunction will get enhanced. It is time to ask for help if you're not being able to cope, okay? Their support system, like I said, do you have access to friends, relatives, healthcare providers, mental health providers? Are your neighbors helpful? What's the social support system like? Your life experience. Is this your first loss? Is this a multiple loss? Is this a compounded loss? How did you handle previous losses? What does loss mean to you? So all of these experiences and the person's worldview. Yes, death is the inevitable consequence of living. That is the worldview of palliative care people, right? And or worldview that, see, this is how it had to happen. Yeah, nobody is immortal. My worldview could be that this is not right. My worldview is that there is inequity in the healthcare system, and we did not get the right kind of care that we needed. So I'm angry, and my worldview is that I'm a victim of external circumstances. I could have done a better job had people been more cooperative, whatever. Blame, this, that, guilt. Now, if you are someone who's trying to support somebody going through this kind of grieving process, you have to know what these 6 things are. There is no template for grief. 2 people who have lost a loved one will not have the same experience. Absolutely not. They might be of the same age. They might have lost a parent to the exact same illness at the exact same time. But all of these 1 to 6 come into play. And that is going to really tell you how this person is going to go through the grieving process. Now, this theorist, Therapies, she also introduced 2 additional tasks to Worden. So Worden's was accept the reality of loss, process the pain, adjust to a world without the deceased, and spiritually relocate somebody. But here she says, in addition to that, you also have to discover your new sense of identity without that person in your life. Okay, and seek meaning in life. Find a way to make sense of the loss as a catalyst for personal growth. Now, not everybody comes out of loss better. Some people pathologically, they go into a pathological spin, and we're going to talk about that in a minute. But seeking meaning is a very, very important part of it, and different people make meaning out of it in different ways. Okay, now the last theory I'm just going to quickly touch upon is the dual process model. And this came about more recently in 1999. And what they basically say is that grief is a 2-dimensional process. At the same time, we are working with loss and we're working with restoration. So loss orientation means all the emotional aspects of the grief. I'm feeling angry, guilty, whatever it might be. But at the same time, I also have to focus on practical changes in my life so I can move forward. And these 2 things happen simultaneously. In the immediate aftermath of a loss, you are more loss-oriented, more dealing with the emotions. But over a period of time, you have to start working on the practical aspects. Yes, you will slide back to emotional distress from time to time. Grief happens in waves. This theory of time heals everything is not true at all. You grow into the grief. The grief doesn't diminish. But as people who are helping, we need to remember that this is ongoing work. And for some people, it's a lifetime's work. They have to keep on working with this. Okay. And we have to permit people to oscillate. It's not like, okay, it's been 2.5 months for me. A lot of people in my family have expressed that loss and everything. They've moved on. For me now, finally coming away from there, I feel like it's starting up for me now. And there have been times when I've thought about it and said, I should be done with this by now. But no, there is no fixed mourning period. And for different people, it will come up at different times. Yeah, and we have to give ourselves permission for that, and we have to give other people permission for that. This thing of, come on now, don't cry, this person is in a better place, move on, it's time to move on. People work with restoration and loss at different paces, and we have to allow for it. Now, when it comes to grief, there is the experience of grief, what I'm experiencing inside, it's how I express it, and then how I adapt to the loss. So Doka and Martin are, again, more contemporary theorists from 2010, who talk about this, the three aspects of grief. And how we express grief depends on our styles, right? So earlier, what used to happen is we looked at it more from like a gender stereotypical point of view. Okay, boys don't cry, women are more expressive, women will reach out and talk to one another, men tend to be stoic, or ideally they should be stoic, etc., etc. So we're very gendered. Later on, people started talking about masculine versus feminine ways of dealing with grief, but then people like Doka and Martin said, no, that is still stereotyping. So we're still putting it in sort of gender stereotypes. Let's not do that. And so that's when they came up with this idea of intuitive versus instrumental. And now what does this differentiation mean? And this is irrespective of gender. All of us have both these aspects in us. For some people, one is more dominant than the other, or depending on the situation, we will lean into one style more than the other. Okay. So intuitive basically is more emotional and expressive. I'm able to express my emotions and feelings, and I look out, I'm in touch with my feelings. I know I'm struggling. I'm going to ask for help. Okay. Instrumental people are people who prefer to put their energy into practical, task-oriented stuff. I'm going to solve this problem. I'm going to figure out, okay, now that I have to decide on the property issues, I have to go and get the legal heirship certificate. I better close the bank accounts. I better do this. That's the focus. And they prefer to talk about problems over feelings, and they focus on problem solving. Now, that doesn't mean we're either or, okay? So in the first 2 months of my bereavement, I was entirely instrumental. Not a tear. For me, it was, okay, now what do I do with my mother's dogs? What do I do with this? What do I do with the staff? What do I do with this house? Okay, I'll get the paperwork done, etc., etc., etc. There were people who are more intuitive. In fact, the people who were encouraging me to be more intuitive, more expressive. And I remember telling them, I cannot afford to start getting emotional now, because I think if I get emotional now, I'm not going to be able to function. So there was a very concerted effort to say, no, I'm just going to focus on the tasks on hand. And that's where there will be a time to feel vulnerable and all of that, but now is not the time. Now, similarly, you are experiencing grief and loss. Are you going to be intuitive at work and having a meltdown all over the place, going to your boss and crying, going to your colleague and crying? No. At work, you're probably going to be a little bit more instrumental. Your intuitiveness will come out when you are amongst people that you feel safe, people that you trust, and that's more likely where it will happen. So most of us are blended, okay? But there are some people who have this dissonance primarily because of societal pressure, especially in communities where they say boys don't cry. It would be the most tremendous loss this man has experienced, but he is not supposed to cry. So there is a dissonance. And because he's not allowed to express his emotions, that is going to be dissonant inside. It's going to come out in unhealthy ways somewhere else. So this thing that we tell little boys, oh, you're the man of the house now, that's causing dissonance. So we have to be mindful. Let people have a blended approach to it. Give them the space and the vulnerability to be intuitive. Let them also be instrumental. I cannot tell you how many people came up to me and said, are you okay? Because you're not showing any emotion. Does the loss seem less heavy? No, it's not. It's just that in that moment, that is what served me. And I think that's what we need to respect about other people. But of course, that can also get into a pathological space if we don't realize it and acknowledge it. Okay, and grief does not exist in a vacuum, like we know. Individual, family, community, there's a ripple effect through all of it. There is something called anticipatory grief, which is grief that is felt in anticipation of an impending loss. And that could be, and it's before the loss. So it could be at the time of a terminal illness diagnosis. You've done chemotherapy, the test results have come, person hasn't responded, you know it's not going to go well. Even before a major life change, like the end of a relationship or a divorce or the loss of a job, that is also anticipatory grief. And it is it can be a very complex and intense experience because the loss hasn't yet happened. But your body and your mind and your heart are reacting like as if the loss is already here. Okay. Now, if it is well managed, if I recognize that this person is experiencing anticipatory grief, I can actually help them prepare and deal better once the loss actually takes place, because this is almost like a practice run. But if it is mismanaged, and if I dismiss somebody saying, what's wrong with you? Stop behaving like this person is already dead. They're still here. There's so much more to do. I may just impair their coping mechanism and lead to worse outcomes because I'm not giving them it's like a pressure cooker. You need to let off that little bit of steam every now and then, otherwise this thing is going to explode. Okay, so anticipatory grief is a real thing. If you are working in palliative care, you're going to see it a lot, not just in families, but also in the patients themselves. Anticipatory grief over leaving people behind. There is a very poignant kind of grief called disenfranchised grief. Disenfranchised grief. Disenfranchised grief is grief that is not openly acknowledged, it is not socially supported, and it is considered unacceptable by others. Okay. Grief that is not openly acknowledged, not socially supported, or considered unacceptable by others. What kind of grief is not socially supported? What kind of grief is unacceptable? And what kind of grief has no place in society?
The persons who are not couples legally or living in a relationship, somebody who is not legally bounded, but they're emotionally bounded and live in a relationship, and some of the partner might have encountered some disease and loss, and which can't be openly socially acceptable by others, or something affairs, who have affairs, and the relationship of the affair person may not express it socially because they are not legally bounded, they are not socially acceptable by the society, and that affairs, and one of them encountered something, they should not show it. Something such.
Absolutely. So that is one. Relationships that are not recognized. There's a huge thing going on in the Supreme Court right now about same-sex marriage. So what happens then when a partner you love, who you've spent your life with, have a stable relationship with, society just does not recognize your loss as a legally appropriate thing. Death of a criminal, yes. Death of a criminal? I think of all these mass shootings that happen in the US, and some child who, whatever has happened, he's gone out, he's shot a whole bunch of other children or teachers. What about the grief of that mother? That's disenfranchised grief. Divorce. Okay, I divorced my husband. He died. I don't have the right to mourn him because, hey, we're divorced. So those kind of relationships are susceptible to disenfranchised grief. And like I said, it's relationships that are not recognized because people didn't know, like Ravi said, it could be an affair, it could be a clandestine affair, it could be a same-sex, non-traditional relationship. The way the person died is not supported, like a drug overdose or suicide, because in many cultures, those are not acceptable, right? And it is also experienced when the loss is not a person. It could be a pet. For some people, their pet is their family, right? But they're not given that space to grieve. A failed marriage, unfulfilled dreams. I might be grieving about the fact that I gave up 5 years of my life to look after somebody, but my grief is somehow not supported because they're like, come on, I mean, what greater service than to look after somebody who's sick? But hey, in those 5 years, I could have gone to college. Now I've missed out on that opportunity. opportunity, and I'm grieving the loss of that, but it's not something that is tasteful for other people to talk about. And high risk individuals, people who have a history of addiction, mental illness, criminal record, and you, my friends, all you healthcare providers are at high risk for disenfranchised grief, because professionally you are taught that you are not allowed to attach yourselves to your patients and grieve their loss. So the grief of healthcare workers, especially, sometimes is not supported professionally. But now I'm really happy to say that the narrative around that is changing. We're looking at burnout, we're looking at distress, we're looking at those kind of things. Humanizing healthcare is a new trend. Hopefully it lasts. And but for the longest time, healthcare providers were at very high risk for disenfranchised grief. Parul is saying, in acute illness and near-death experience of loved ones, does anticipatory grief be prolonged? Or what is it called then? As a result, is not yet death. A good question. It doesn't have to culminate in death. It doesn't have to culminate in death for the experience to be real. I could I could just have anticipatory grief, because see, the person has had a near-death experience, but they're still somebody you love and you stand to lose, right? So grief is grief. What is it called? I don't know if there's a term specifically, if it's like a, cried wolf kind of situation. It is grief. Okay. So it does not necessarily have to result in death. Okay. This is complicated grief. Complicated grief. The pandemic has opened up an epidemic of complicated grief. What is complicated grief? Can I ask somebody who has not spoken yet to please read out the different points on the screen at the moment? Somebody who hasn't yet spoken. There are many people who haven't spoken. Would someone like to unmute and read this out? Punita, Shaji, Meera, I'm just naming people randomly.
Characterized by intense and persistent yearning or longing for the deceased. Difficulty accepting the death. Persistent feelings of disbelief or shock. Emotional numbness or detachment. Difficulty experiencing positive emotions. Difficulty engaging in activities that were previously enjoyed. Guilt or self-blame related to death. Intense feelings of anger or bitterness. Difficulty trusting others or forming new relationships. Preoccupation with thoughts of the deceased. Difficulty with daily functioning such as work, school, or self-care.
Thank you, Sairu. So yeah, very complicated. And why I mentioned the pandemic is because there are certain triggers that are likely to lead to complicated grief than others. Okay. Now, nature of the relationship with the deceased person is one. I could have a very complicated relationship with that person. Okay. I'll give you an example. We once encountered a lady whose husband had a progressive neurological disease, and he had ALS, and they've been married for 50 years. She looked after him the whole time. Now, he was a very dominant man. And he was, there was indication of emotional abuse and things like that. I don't know if there was physical abuse. But as he got more and more debilitated, it was almost cruel, because even though they were very affluent and very well off, he insisted that they would not get a nurse and she would do everything. He wanted her to do everything in spite of the fact that they could afford care. And as he lost his speech, as he lost his movement, he got more and more passive aggressive. He eventually died. And her whole life, 50 years, out of 50 years, they were married. Yeah, they were married for about 40 years, sorry. Now, suddenly this guy dies. This woman doesn't know what to do with her life because she does not have an identity of her own. She has never made a decision on her own. She's always been submissive. So what is her mourning period like? She's also too ashamed to admit that she's relieved that he's gone. You see how complex it gets? I'm so glad he's gone. But I shouldn't be saying that. Okay. So nature of the relationship. It could be a conflicted relationship, it could be a dominant relationship, it could be an abusive relationship, it could be whatever else. The second trigger is that circumstances of the death. COVID. Someone gets a cough, cold, can't, not feeling too good, goes to the hospital, never comes back. No mourning, no funeral, none of it. And I'm sorry if this is triggering for some of you, but COVID was a prime example of circumstances of the death. For me, circumstances of the death was the fact that I watched her die on a video call. It has complicated my grieving process. I'm not experiencing complicated grief in the sense that I'm not being able to function, but yes, it was a complicating factor for me at the time. Events that occur after the death. What if that person was the safety net and now suddenly there is no security? What if that person was the nurturer? What if on the death of the person, huge property dispute and the family has been fragmented because suddenly, there's no will, everybody is fighting over who gets what. And that has complicated the grieving process. This didn't happen with me, but I'm imagining that if I really loved my parent and I have 3 siblings, my parent has died, leaving behind a giant mess. And now my siblings and I are fighting over it. It is going to complicate the way in which I'm experiencing grief. Lack of social support. If you're isolated, if you don't have help, it can complicate your grief. And complicated grief will dominate and overshadow your life. And after 2020, it was actually included in, it's actually been included in the ICD and as now called prolonged grief disorder. Okay. And just to differentiate grief and depression have many common characteristics, which include intense sadness, fatigue, sleep and appetite disturbance, low energy, loss of pleasure, difficulty concentrating, overwhelming emotions that interfere with your ability to cope with everyday stresses. So sometimes it's very difficult. And this is something I'll be very cautious about to tell you. When you encounter somebody in your practice, please, before you label them as depressed, please assess whether they're actually grieving, whether it's anticipatory grief. Remember, grief can happen before the loss. It doesn't have to happen after the loss. Now, how do you differentiate between grief and depression? Grief is specifically triggered by the loss of a person or a thing that is of value, a specific thing, okay? While I'm grieving, I can still stay connected to other people. I might periodically laugh. I might still go for a movie. I might go out to dinner. I'm still grieving. I might have friends over, whatever, but I'm continuing to function. And the treatment is through grief-focused therapy. My therapist is working with me on that, and that is what is keeping me going. With depression, it's an actual mental health disorder, and it can be triggered by a variety of factors. It could be any kind of life stressor, the loss of a job. It could be that just conflict in a relationship. It could be just unhealthy coping mechanisms. It could be substance use. It could be many things. And the loss of connection there is a loss of connection with others. There's withdrawal, very, very difficult to experience even brief moments of pleasure. And the treatment here may require pharmacology as well. So grief and depression share characteristics, but this is the defining feature, that grief is specifically tied to a loss or an event. Depression is diffuse. We don't know what exactly causes it. And a person who's grieving is still able to stay connected to other people and do other activities, whereas a person who is depressed. Now, complicated grief and depression, again, that's more difficult because complicated grief gets prolonged and people actually withdraw. It dominates their lives. At which point, if it goes on for about 6 months after the death of a person, we generally don't tend to diagnose for depression. We allow it, to be seen as grief. But if we see that there's no progress being made, it is time to call in a psychologist or a psychiatrist. Okay. And unresolved grief will manifest in different ways, and it might seem like psychosomatic, but there could be all kinds of things that emerge as a result of unresolved grief. The person may appear stuck in a particular stage. They might be angry all the time. They might be, still in denial. They might still be they might be feeling extremely low and stuck in that sort of zone, not wanting to socialize, etc. Acting out behavior, especially in children. Children might express grief by going out and getting into trouble, fighting on the playground, getting into fights with their classmates, failing their classes, not doing well in their studies. These are signs of grief also in children because they are expressing it differently. Suicidal ideation or attempts for people who are extremely unhealthily attached. If they had very pathological attachment styles to the person who has died, they themselves might have suicidal ideation, or they might even attempt it. And a marked alteration in the style of living. Some people just stop caring about their hygiene. People who are really cleanliness freaks don't care about how their house looks now. They not someone who is very fitness conscious doesn't care about their health anymore. Those kind of things could also be signs of unresolved grief. And disruption of important relationships. I don't care what my boss says, to hell with it. Or my friend is calling, I don't feel like talking to them. Or I get into arguments, I might lose my temper very easily, I'm irritated all the time. Those are also signs of unresolved grief. Okay. I'm not going to go into this. This is there in the slides as well as in the module. And in the module itself, I've given you, details about each of these validated tools to assess for grief. So please go through that in your own time. And how do you manage grief? One is education. We need to talk about it, not just amongst us as team members, but even to families. Grief is normal. Anticipatory grief is a thing. It is okay to feel the way you're feeling, because this is a big loss, whether it's a positive or negative relationship. This person has occupied a big space in your life. So yes, it is normal for you to feel anger. It is normal for you to feel grief manifests in different ways. Educating the family, educating our team members is really important. Counseling, I could not vote for this more than I already do. Counseling is really, really important, because it's not easy. It's not enough to talk to people within your family, because everybody's going through it in their own way and form. You need somebody who is more objective on the outside to help you process it, because each of us within our own families have different coping styles. And we need to reach out to somebody who can help us identify our strengths and our resilience. Support groups help in some cases. That lady I was talking about, she finally joined a support group for ALS caregivers, and she's found a lot of solace and comfort over there. And pharmacotherapy, sometimes it is indicated. Sometimes you need people to see a psychiatrist, to see a doctor, to bring the anxiety levels under control, maybe to also help with insomnia, whatever it might be. Okay. Psychological intervention frameworks, again, I'm just going to touch upon it quite briefly. There is CBT, cognitive behavior therapy. And again, the details are there in the module that I have shared. And this is very clear cut. CBT tends to be very mechanistic in that sense, because you have some goals. It's a short-term therapy option, and you're helping people identify changes in negative thought patterns and stuff. You have to be trained in CBT to be able to do it. Personally, I find it very Western also in its modality. I tend to lean a little bit more on humanistic, towards humanistic interventions. Mindfulness-based interventions, there is now something called mindfulness-based cognitive behavior therapy also, which is a little bit more holistic in its approach. And it's also about coming back into the moment, grounding yourself, so on and so forth. Narrative therapy, storytelling is a great way to share your distress and to have somebody receive it and help you step out of your story, to maybe fix the script a little bit for yourself. And all of us have a story we tell ourselves. We all have a story we tell ourselves. Sometimes that story we tell ourselves is not helping us. It is reinforcing certain negative patterns. Narrative therapy helps us reframe the story and to step out of that. Okay, and a couple of others more. Acceptance and commitment therapy. This is a therapy, again, it focuses on encouraging people to accept their feelings and taking action towards goals and values. It's very doing it's a very focused kind of therapy. Trauma-focused therapy takes into account that there are people who experience traumatic grief. Trauma could be because of various reasons. And some people definitely need trauma-informed care, because the trauma could be not just from the time that they were caregivers, but also from even, from early part of their relationship with the person that they are with. And really the choice of framework will depend on the individual specific needs. I cannot use cognitive behavior therapy for somebody who does not think like that, who is not receptive to it. I cannot sit and do meditation for somebody who is unable to practice it in that moment. Okay, so it has to be tailored to what the person is able to receive, and it also depends on the expertise of the therapist. Just like doctors have specialties, counselors also have different schools of approaches and thought, and you have to find the right fit. I cannot force rational emotive behavior therapy on somebody who does not like to be challenged. I could be doing them more harm. So please be mindful that these psychological interventions that I've told you require training, and it requires very specific kind of interventions that have to be tailored to the person that we are trying to help. Okay, what are the goals? To increase the reality of the loss, to help, rather than saying increase the reality, to help them accept the reality of loss would be a more appropriate term. To help the bereaved deal with both the experienced and latent effect. I have experienced it, but what are my emotions about it inside that I'm not talking about? Let's talk about that. Okay. I have been a great daughter, dutiful daughter. My latent feeling about that is that I never want to hear another person tell me that again. And I need to work with that anger that I have, that like people would tell me that, oh, what a great service you did. What a sacred thing to do, to look after. It is a blessing to be able to look after your mother at such a difficult time of her life. I can tell you there was absolutely nothing sacred about having to give an enema in the middle at 3 o'clock in the morning, or sometimes to manually evacuate her bowel. I did not feel like I was feeling, very close to God at that point. And it's so what is the experience? What is the latent affect associated with it? And to help people process that. Okay. To help the bereaved overcome impediments to readjustment. I might be sabotaging myself. So I basically surrounded myself with tasks that I had to do, which I thought that only I could do. I wanted to be in control of it. And that was my way of, I stayed on in my mother's house for 2 months, because that's the way I was putting off the actual emotional grieving process. And I had convinced myself that, only I can do this. Only I can do the bank work. Only I can do that. Whereas a lot of people were saying that, it's okay. It's time to let go. So I was sabotaging my own grieving and healing process in that sense. And I needed a therapist to actually coax me out of that. And I can tell you that it has helped a great deal. To encourage the bereaved to make a healthy emotional withdrawal from the deceased and reinvest energy into other relationships, not easy. But we don't achieve this if we tell somebody they're in a better place. At least they're not suffering anymore. That doesn't help, because you're not acknowledging that it was painful. Now, in order to healthily withdraw, you have to accept that it was a difficult thing. Now, let's move on from there. Not by saying, hey, it's over, let's move on. No, it has to happen gradually. You have to experience whatever pain and difficult emotions, and it has to be done in a safe space. And then from there, we can move on to the next thing. Grief management, most people resolve to a level of functioning. It takes about a year or so. Some people might take a longer time. That's okay. Depends on the kind of social support, depends on their own resilience levels. And we as people really need to advocate for sufficient time off from work for the bereaved, especially in the first few weeks of bereavement. I strongly believe that, especially when it comes to the loss of somebody who is very close to you, it is important that bereavement, that bereavement leave is something that has to come into place, because a lot of people cannot afford to not be at work at a time like that. Also, post-bereavement expenses are high. You have funeral expenses, this, that, whatever. A lot of people believe that they cannot take time off work, because if they do, they'll get a salary cut. Now, for a lot of people, it may not be the first 2 weeks that they need leave. Maybe 1 month later, they need some time off now that all the work is done. So we need to advocate for these kind of things. I was recently asked, what are the best practices around this? I said, I don't know any best practices, but hey, all of us are palliative care people. Shouldn't we be setting the best practice for this? And we need to also remember that grief spikes right through life, and it's not something that will be resolved, in a specific time frame. Now, I'm very quickly going to go through this. Bereavement is the actual event of loss, and it's the period that follows soon after a person has died. It is a period of intense suffering. It could be marked by impaired interpersonal and social relationships. This is also a time of elevated risks to mental health, substance use, panic attacks, all kinds of things, unhealthy coping mechanisms. And this is a very high risk time for that. And what are some of the emotions we feel at bereavement? Sadness, of course, anger, numbness. Some people just don't feel anything. Panic, some people have panic attacks, a lot of anxiety. Some people are just relieved that the whole thing is over. Some people feel a lot of guilt. And any number of these can happen in any number of combinations. Okay, so it is a complex time. And there are 3 phases I want you to think about following death. There's the immediate loss of the person. There are secondary losses, the role as my loss now. Now, who am I now that I'm not a caregiver? Where is the palliative care team I used to talk to every day? I used to talk to Dr. Raj, Rajni Bhatt, Rup Gursani, Savita Bitola, Dr. Sunil, everybody almost every day. Now suddenly I suddenly felt the loss of that for a little while. But I also, all the other support systems, family coming around, helping me take care of things. Now slowly they've gone back to their lives. And further losses also in terms of wow, now I was going to go off and do this, but now I've been left with something else to do. And there's a loss of income. There's a loss of a matriarch in my family. There's a loss of a nurturing adult, and so on and so forth. Okay. And what are some of the protective things that you need to look out for? Does the person have good social support? Build on it. Does the person have healthy coping styles? Strengthen those healthy coping styles. Resilience. Some people have come through a lot of difficult times in their lives. Remind them that they've come through those times and they have that resilience in them. Communication is very, very important. Some people may not have the language. We need to give them the language to communicate their distress, and appropriate and timely healthcare responses. The bereaved people need to have access to healthcare, because this is a time also where, you've gone through a period of intense caregiving where you've powered through with adrenaline. How many of you, when a crisis has passed, just collapse? So make sure that there is healthcare available. And anger, like I said, is a particularly difficult emotion. And as a society, we really don't encourage the expression of anger, and it can feel very, very powerful and menacing. But if you don't express anger, it does come out in unhealthy ways. We're not allowed to express anger against people who are sick and dying or dead. And, it's not considered socially acceptable, but if we don't find a safe space to do it, it comes out in other ways. Grudges, guilt, overreaction, loss of temper, explosive outbursts, withdrawing from society, depression, burnout, low self-esteem. So anger has to be given a place to be expressed. Okay. And when you're providing bereavement support, please try and identify and support their coping strategies, identify and reduce risk factors, identify and facilitate protective factors, what I just showed you, and establish a channel for future support. Just because the patient has died does not mean that the care is over, because we as palliative care providers have to continue to support families well after the bereavement is done. And we have to facilitate the grieving process through those different frameworks, and provide the emotional support. And I know some of the clinicians do that beautifully, where they will just a phone call from a nurse who took care of the person who has died goes a really long way. And helping them manage stress and anxiety. Practical concerns. Have you been able to get your, life insurance policy cleared? Do you need some help with, do you need my signature? I remember, the doctor came through beautifully because I needed a death certificate, I thought. And later on, Dr. Sunil and I were part of an exchange where I was later told that, it was a death certificate did not rely on the doctor coming and declaring that death at night. And but these are information, these are bits of information that can really get people stuck. So to demystify the process for them is really, really important. Reducing the risk of complications in the sense of conflict resolution and so on. I'm not going to get into that right now. Okay, now there are 5 stages of bereavement support. Right from the time that the family comes to you and registers as a patient, that's when your assessment begins. What is this family structure? Who is talking to whom? Are they in denial? Do you think that they have understood that this is a terminal illness? What is the level of understanding of the disease, so on and so forth? That will tell you how prepared these people are. Imminent death is when it's about to happen, the day of the death, 2 weeks after the death, and 1 month after. I'm going to just tell you very quickly. These slides are available to you. When someone comes to you for the first time, assess the caregiver's risk of complicated grief. How are they attached? Do they have a complicated relationship with the person? Is this someone who has bad coping strategies like self-harm, or are they going to reach for substance use, or what are some of the potential risk factors? And you need to be able to provide information and psychoeducation. And psychoeducation, when you give somebody, you focus on typically preparing them that, okay, being a caregiver is not an easy task. Okay, and what is typically expected of you, what kind of support you can get, how will the palliative care team be of assistance? Are they also taking care of other relatives? Are there children, older people in the family? How are they managing all of that? Self-care strategies right from the start. They need some time off, some respite care, lessons in self-care, things like that. And if it is necessary, information on death and bereavement, it's not always warranted in the first assessment. When death is imminent, when you know that the person is going to die, assess the family's preparedness for death. Discussions regarding death decisions. This is usually the job of the team, saying, okay, it looks like we don't have a lot of time left. So here are some of, these are some of the interventions that can be done. Would you like to take the person home? Do you want them to be cared for in the inpatient facility, so on and so forth? And provide practical information. Tell them, okay, you might hear a death rattle. These are some of the physical changes that you're probably going to see. So prepare them for that. And help them make decisions. Do you need to call XYZ in your family? Who is not here that you would like to have present? Who's going to make these decisions? Those kind of things which people are in a bit of a brain fog. They can't really think about it at that point in time. At the time of death, assess the level of trauma and provide appropriate support where needed. So you need to be able to connect them to social systems, support systems, help them with practical tasks like filling out the death certificate, telling them what steps they need to follow. At least one palliative care team member should be with them till they leave the hospital premises, and a medical person connected to the care of the deceased. If they're able to be there, it's great, because any questions that the family might have, relatives coming in might have, it's good for a medical person to be there to answer those questions. 2 weeks after the death. Why 2 weeks? Because that's the time that the funeral is done, the initial pujas and the ceremonies are done. And this is a good time to check in with them, even through a phone call, and say, how did it go? How were the ceremonies? Did the rituals go according to how you wanted? Were your other family members there? If you had a relationship with this family member, then they might have told you that, I'm really worried about how my brother's going to react. Ask, did it go okay with your brother? If you've known the patient, share a positive memory about that person, because death is a taboo subject. And a lot of the times people avoid talking about the person who has died. But if you share a positive memory, that's a great way to honor the person who has died. And bring up any other concerns that they might have shared with you earlier, like, I'm so worried about my finances. Or they might have told you, I'm really worried about how my kids are going to handle it. Check in with them about that. It goes a long way in empathy, because they say, oh God, they actually remember this and they've asked me about it. Okay. And finally, 1 month later. Why? Because that's when things go quiet. Family has left. friends have moved on with their lives. This is where the loneliness will kick in. This is where people are really sitting with their emotions. And call in, ask for long-term things like, health risks, like, have you been sleeping? Do you have insomnia? Have you been eating? Who are you in touch with? If the caregiver has quit their job to look after the person, so are you thinking of going back to work? Landscape questions like that. And is there anything that you're struggling with? And don't shy away from addressing the person by name. Now, my final slide to you is this, the do's and don'ts, very practical things. Please don't say, call me if you need anything, because the person is already dealing with a lot. The last thing they need to do is think about one more thing to tell you. Instead, offer very specific forms of practical support. Now, I'm not just talking about as a care provider, I'm talking about just as a friend and a neighbor, okay? Offer to do things that you can definitely do. Take their dog for a walk, bring some vegetables home, take care of elderly parents. Let me drive your mother to the doctor. You stay at home, get some alone time, those kind of things. Please don't avoid taking the name of the deceased person. It's really important for the bereaved person to remember the person who has died. If you did not know the person, ask the bereaved person to tell me something about your father. Tell me something about your mom. Okay. Don't rush in to say something for the sake of it. Silence can be a very, very powerful tool. Just offer to sit with them. You can say, I really don't know what to say, but I'm here. I'd like to be able to support you in any other way, but I don't know what to say at the moment. Please don't say things like he or she is in a better place. It is really trite. It angers people. It completely diminishes the struggle and the pain. So please acknowledge it. This must be really hard for you, okay? And please avoid comparing their story to somebody else's or stepping in with your story immediately. There might be a time and place for it, but maybe not right then and there. I know we're really at the end of time, but I said I was going to be a little personal about this. So for me, I've taught grief and bereavement now for, like I said, for a long time. Teaching it now has been completely different experience for me, because I realize now that there is no template for grief. And we can go with all the theories and all the frameworks, but how we experience grief is really down to us individually. And because I feel like this is an important place where I can share it. This is my mom when she was young, and she was a feisty woman. She did go through her own difficulties. My mother had a lifelong struggle with addiction, and that had complicated a lot of things right through. I mean, we were expecting her to die of various causes over the last 10 years, but she powered through it all, and we called her a dragon. And towards the end, it was something completely unexpected that got her, which was interstitial lung disease, and it was a very, very rapidly evolving thing. And for me, even teaching this class is a bit of processing of the grief, because I find that there is a method to the madness, and more than anything else, understanding, acknowledging grief as something real, naming it can be really, really helpful. So this was like our first picture together, and this was our last picture together. And I think that these are the relationships, no matter how complicated they are. All of us at some point either are caregivers or are going to need care or will provide care to somebody. So acquainting ourselves with grief is really, really important, because whether we're doing it professionally or personally, it is going to be a very intimate companion. So I will encourage you to read as much as possible about grief, experience your grief, whatever it might be, and go through the process of it. So I will stop with that. I have left precisely 1 minute for questions. But I know that there are a few in the chat box. Let me quickly go through them. In a queue, okay, fine. How can we work on this bereavement period cover and caregiver allowance? There are some countries that are providing caregiver allowances. We really need to advocate for this. There is a movement now for informal caregivers, that is people in the family, right? There's a lot of literature out there about informal caregiving and advocating for them. How do they get compensated for their time, for their effort? It's not an easy conversation, especially in a cultural context like India, where we see caregiving as a duty. And, it's considered to be something that it is a blessing. The point is that it takes a huge toll mentally, emotionally, spiritually, financially on people. So there is a movement. There's a lot about it. You and I can connect separately about that, and we can talk about it. Yeah, bereavement support. I would say that all of us who are invested in this, we need to advocate for bereavement leave as well. You can't. I was telling a colleague recently that this is the least competent I've been in the last 10 years. And it's taken a lot of energy to just, and it's lucky for me that it's in a safe space in Pallium, and, it's a subject that I can rattle off. But, juggling between practical responsibilities and work is very tough. So I would say join us. Let's advocate for this, and let's create the best practice that needs to be created. Ravi, yes, you have your hand up.
Kind of. Ma'am, it's really a wonderful presentation, and I've been really emotionally connected to whatever which you have said. And I have a case recently. She's a 27 years old lady, married. She's a love marriage. They made her both the sides parents to. It is an intercaste marriage, so they both of them had made the parents to agree to the marriage. And it's last year, July 2022, they have been married. And after marriage of 3 months, she started experiencing pain in the abdomen, epigastric pain, this and that. So they went on very investigations, pancreatitis, and later on stumbled upon the cancer in the stage 4 pancreas, which is the worst of all the things. And she came to me a few days back, which she emotionally bursted out that she had the love marriage, and after hoping that everything would be very good, very well settled, but things turned upside down to her. The husband is very much friendly, and he's a best friend to her. Before marriage, they had the friendship relationship, and is very supportive. She has an elder sister. She was married, but she doesn't have any kids. So she raised her younger sibling as her own child. And except the girl, the rest of them, they knew that what could be the outcome of the disease. And everybody, most of them, they visited the hospitals, and they told that it could be the end of the EVO-LC case, and she could have hardly 3 months time. I can't figure out how many months or weeks, but the thing is that she was taken up for chemotherapy and all the stuff and all that's going on, and she was planned for everything. So currently her sister is in anticipatory grief because she bursted out when nobody is alone. She felt that it becoming very difficult to be happy in front of my child, and it is like a suffocating pain that I couldn't express my grief in front of everybody, because if I express these things to my parents, they will get shattered down, they will emotionally burst out, something bad will happen. And to be smile at to be happy, to enact in a happy mood, to console my sister, it would taking me emotional trauma inside me. I couldn't able to do it, but I have to do it for the sake of my sister. And the husband, even he knows that something, but the patient, she's Vasanta, her name, and she consoles her parents that she has cancer, but it will be get cured. So why do you bother much? So that made me stuck that she's in the view that she will be cured of, which inevitably she won't, and ultimately have to be part in the grief and bereavement process, which in the first attempt, I made a rapport, which I haven't delved everything to the patient, but I addressed the pain component because of the pain which she was feeling.
Dr. Ravi, I think, was it only me who lost you?
No, we lost.
Chemotherapy, this and that. So this anticipatory grief and the husband dealing with these things and emotionally, how could we address? I hope my doubt has been clearly explained to you.
Okay, so there are several things here. One is that it seems like there's some collusion. I think there is also not complete. I think different family members have a different understanding of the illness and the prognostication. I would say before we tackle the grief and anticipatory grief, let's go back to basic communication, right? And to see where everybody is. Where are you with this? Now, it's clear that she thinks she's going to be cured. What has given her that impression that she's going to be cured? It's clear that somebody else in the family needs to put up a brave front. Why is it that that person is not able to be vulnerable? It's because there is some amount of collusion happening here. Dr. Amrita, what is your take on it? There is clearly some, as long as people are not on the same page, you are not going to be able to help them authentically express and experience their emotions. People are, yeah, Amrita, please.
Yes, Smriti, I do agree with that. I think, Dr. Ravi, we need to explore exactly what is their take on that, like exactly where, what is that insight we need to explore that made her give this idea that she would be cured, and where did she get that idea from that she might get cured. So I think that would be the first step, exploring that. And then I think, as Smriti has already mentioned, we'll have to explore each one's concern, including the family members, like their insight on, and maybe slowly proceeding with the like pollution breaking would be the first step. Right.
And I completely agree with you. I think those are the steps. I also, the fact that why is it important to mention that it's a love marriage, and it's because a lot of things have happened in the past for them to come together. There's also probably a sense of guilt about, after all of that, this is what it's come to. We've defied so many social norms, and now it's come to this. They're young, they've just been married 3 months. Obviously, it's not like they've lived 50 years together and now this is happening. This is happening so early in their very non-traditional sort of, I'm assuming non-traditional in their context setup. I will also, this is an assumption on my part, but very often, see, if it's someone who can read, write, and has a sense of the world, if she's going for chemotherapy, she knows she's seriously sick. And sometimes we put on a brave front. So patient and family do the same thing. They're all trying to protect one another. And there, somewhere between all of that, people are not being able to be authentic and express their vulnerability and to cry together or to, go through this thing together. So like Amrita said, understand firstly from the family members individually, where are we? Where do you think we are? Okay. How are we doing? How is she doing? Ask her that. Okay. Then we can work on this. Obviously, the person who came to you and cried when you said she has anticipatory grief, it's because she probably has a realistic idea of where this disease is going, right? So maybe work with her. What is scaring you? Why is it that you don't want her to know the truth? So we have to work with people's fears. We need to understand why they're gatekeeping and why they're not letting us, talk to them about the seriousness of the illness and so on and so forth. So it's a longer conversation. I will need a lot more details to be able to help you better with this. But if you
definitely need assistance in this, because definitely it would be a Herculean task for me. And it is anticipated that it has a fatal outcome.
So please send me the case, and I'll work with Dr. Amrita and Shri Priya to.
Your email ID is something which I can in touch with you, because it definitely helps me out.
I'll do my best. Thank you very much, everyone. And
so actually I would like to thank Smriti for I have been a part of many sessions that Smriti have done, but this was a different experience, truly a different experience, where she was walking us through her own experience, and that made things a bit more enlightening or clearer to us, and how difficult it was. She was explaining to us, even for a person like Smriti, who has been trained in this and who's a psychologist herself, how the stages of bereavement, how she had handled it, and how she had walked through it. She helped, she told us during her sessions. Thank you so much, Smriti, for that. And yeah, over to Sri Priya.
Thank you, Smriti, ma'am. I still remember that day when you were taking a session for another batch, literally maybe less than 1 week after the sad demise of your mother, and you were as usual enlightening others. And at the nick of leaving the class, you broke the news, and everyone was like shocked. She just Smriti ma'am just said that her mother has passed away a couple of days ago, and then she left the meeting. So I know you as that stronger person, and thank you so much for enlightening us on this topic. Yes, we do know one session is not enough. I believe everyone would agree to that. One session is definitely not enough to learn more from you, and each session has been so enlightening with you. So thank you, Smriti ma'am, and keep do joining us whenever time permits to enlighten us more, to make us better human beings, to make us handle situations more. Thank you so much. And thank you everyone for joining in. I could see at least some of the faces were showing how they could relate themselves. When
before we close, I have to say that if there's only one takeaway, I'll say, forget all the theories and frameworks, ask for help. And I got help from the entire Pallium India team, from Dr. Amrita, from Dr. Sunil, from Sri Priya, everybody. And that's, I think, like they say, it takes a village to raise a child. It also takes a village to go through the bereavement process. So I would say that would be my takeaway. Ask for help. Let's support each other. And thank you very much to all of you for allowing me to, share this story. Thanks, and have a good Sunday. Please, I hope none of you are working tomorrow.
Thank you so much, everyone, for joining in. I will not pester more with over that simple words. Ask for help. So thank you, everyone. See you in the next session. Till then, everyone, take care. Bye-bye.